This is Selma Schimmel in Chicago for the group room. We're at the 2012 Multidisciplinary Symposium in Thoracic Oncology, which is brought to you by ASTRO, IASLC, ASCO, and the University of Chicago. And I am now joined by Dr. James Jett, Professor of Medicine, National Jewish Health, Denver, Colorado. Hello, Dr. Jett.
Good afternoon. Happy to be here.
You're going to spend time talking to us about screening, and maybe we can also work through some of the years of controversy that has finally maybe solidified into how do we screen for lung cancer?
You're absolutely right. The standard dictum for years has been that there's no role for screening for lung cancer, and that's been based on the trials out of the 70s and the 80s, looking at chest x-ray and sputum cytology, which did not show any decrease in lung cancer mortality in those who underwent screening. So for a number of years, the whole issue was totally dormant and dead. And up until recently, the standard position of most of the major organizations, like the U.S. Preventive Health Service and others, has been that there's no role for screening of lung cancer, even in high-risk individuals.
So fast forward and tell us where we are today and how we understand the role of screening, how it impacts clinical outcome and naturally survival.
So the landmark study published just this past year in the New England Journal of Medicine was a randomized trial that looked at screening with chest x-ray versus screening with low-dose CT. And that study showed that you could decrease the number of lung cancer deaths in the CT screening arm by 20% decrease in deaths. So you prevented 1 out of 5 lung cancer deaths on the CT screening arm. That's a landmark study. It's a major improvement in the whole area. It's the first study that has shown that screening of any type decreases lung cancer mortality. That was a study done in high-risk individuals, defined by 30-pack years of smoking and 55 years of age or more was the eligibility criteria.
You moderated a general session here at the conference. You had 3 speakers, and the subjects were uptake of lung cancer screening 1 year later, whom should we screen before lung cancer, and novel screening technologies. Would you be able, in a nutshell, to sort of recap and summarize the most meaningful parts of those talks on behalf of our viewers?
I think the bottom line is that 5 or 6 major organizations in the U.S. now have endorsed the role of screening with low-dose CT scans in high-risk individuals. That basically the high risk is the group that qualified for the National Lung Cancer Screening Trial, and that is the 55 to 75-year-old individual who has smoked currently or formerly 30-pack years of smoking. That's the definition of high risk at this point in time. What came out in this symposium, 2 things. There's risk modeling that's going on. We're trying to figure out who to screen. And obviously, screening test works best if you screen the high-risk individual. So it wouldn't be beneficial to screen somebody like me who has been a never smoker in his or her lifetime. Screening is really beneficial in the people who have the higher risk for the disease.
Novel technologies that you think are on the horizon for further refining detection?
Right. Everyone is interested in biomarkers. Biomarkers are either a blood test or a urine test or a breath test that might indicate that you're at higher risk of developing lung cancer. And it's a very fertile area of research. Right now, a number of companies are looking at various different biomarkers that would increase your potential risk of developing lung cancer in the future. So then the plan is that we come up with good biomarkers, be they breath analysis or be they blood or be they urine markers, that might be combined with risk modeling to try again to predict who's really at risk for developing lung cancer, and then those would be the ones you want to screen.
What about familial or genetic predisposition? Is there no high-risk component for those patients?
Currently, there's been a few papers published about possible markers of lung cancer, but the general consensus is there is no good genetic marker that you could draw on me or you that would say, okay, you should be screened. There is not the equivalent of the BRCA1, BRCA2 mutations that's seen in breast cancer.
If one has a parent?
One has a parent, like if my father or my mother or one of my siblings had lung cancer, the studies suggest that my risk, even though I'm a never smoker, my risk would be about 2, perhaps 3-fold the risk of a never smoker. Now that still is pretty small compared to a first-hand smoker whose risk is 10 to 15 times the risk of a never smoker.
We all grew up in the era that when we would go to the doctor every year, we would get our chest x-ray.
Yeah.
What's the future of the annual chest x-ray?
Don't do it. Very pure and simple. There's no role for chest x-ray in screening. Definitive study on that came out last year in the PLCO, the prostate, lung, colon, ovarian screening trial, randomized people to chest x-ray or nothing, and it showed chest x-ray did not decrease mortality.
Dr. Jett, do you have a closing thought?
The two major impacts on decreasing lung cancer that have occurred in my lifetime are smoking cessation, and don't start if you haven't started, but if you've quit or if you have smoked, quit as soon as possible. That does lower your risk. So that has been shown to decrease deaths from lung cancer. And then the next biggest thing that has happened in mortality reduction is the screening of high-risk individuals with low-dose CT scans.
Thank you so much for really shedding light and helping to clarify this area that's been confusing. A lot of messaging that's been hard for the general public to understand for some time now.
Thank you, my pleasure.
Dr. James Jett, Professor of Medicine, National Jewish Health in Denver, Colorado. Thanks again.